Okay, so the recording has started. So I will go over here to the slideshow and then I'll come pop into the comments every once in a while. All right, so welcome everyone. And those of you who don't know me, my name is Laura Chakis. Actually, there'll be a slide where I'll introduce myself a little bit more. But today we're going to be talking about how to diagnose and treat BFRBs. And also I will point out, because it bothers me, any of you who are perfectionists, I'm really not a major perfectionist, I would say, but the logo is like cut off on both ends. When it's not on presentation mode, it's there, but when it's on presentation mode, it's not. It bothers me, but I'm going to embrace the imperfection. And also there's little gnats around here, so I'm swatting them away if you can still see me. All right, so today we're going to talk about what BFRBs are, how to diagnose them, and then go over the evidence-based treatments for BFRBs, and then talk about how to achieve long-term recovery. So a little bit more about me. So I have specialized in working with clients with BFRBs, along with OCD and anxiety disorders since 2005. And then in 2014, I started the first group therapy for BFRBs. I believe it may still be the only one in the St. Louis area, at least the only one I know of. So I started that with adults first, and then I later had a group for kids, and then also a group for teens. Then it changed through the years. We put the teens with the adults and maybe some younger teens with the kids. And then unfortunately, since the pandemic, I have not gone back to doing kids groups, but I would really love to. So we used to do them all in person, then switched to online. And actually I found with the adults, the online group was actually more better attended because of, as the ease of getting on every week. So that has worked well. But with the kids, I really like doing the interactive. We do art, we make fidgets and all kinds of fun stuff, play BFRB bingo, and that's just harder online. But we are, open and have the space, so hopefully that will get going again soon. And then also in 2018, I created an interactive online course for adults with BFRBs. So this was really taking all of the evidence-based treatments and what I had seen effective with my clients and making it into a course so there's like recorded video modules. It's a 10-week course. And the interactive part is that we do meet weekly for coaching calls. So it's a little different than therapy in that I don't give a diagnosis. I mean, the people, self-diagnose, or maybe they've been diagnosed with a BFRB, but they come in and we just chat about like how each week went, as like after they watch the video, and then they have action steps to do each week, and then we check in, how did that go, and kind of problem solve. So similar to group therapy, but just slightly different in that we're really focusing on the course content. And then, so I found with this evidence-based treatment, whether it's done in the therapy room or online course, that it's really led to long-term recovery. And I've also seen this with a big component of the program is an alumni group that follows up. We meet monthly because, as with probably most any disorder, you can get a lot better, but then time passes, something comes up, and you get worse again. So this alumni group has really kept people better, through the years, and I continue to meet with them, and that's been really positive. So then I've also been training and supervising therapists to become BFRB experts as well, using this effective approach. All right, so first we're going to talk more about what BFRBs are. So basically they are disorders that cause people to pull out their hair or pick their skin, bite their nails, or repeatedly damage their body in some way. Now, I'm sure you all know, or you may yourself bite your nails or pick at your skin some, or we all pull out, gray hairs or pluck our eyebrows, or not everyone, but many people do that. So it's just like any other psychological disorder. It's only a disorder if it results in the substantial physical damage to the hair or skin, or causes some disruption in the person's functioning or significant distress. So, many people bite their nails their whole lives. It's not a big deal if it doesn't cause infections, or if, doesn't stop them from doing anything and doesn't bother them all that much. So we generally don't see nail biters in treatment very often. Occasionally, it will be when they just can't stop and it's causing infections, or just they have to wear band-aids all the time because the nails are bleeding. Um, so the key thing to remember too is that most people with BFRBs really want to stop the behavior. They do not want to be doing the behavior. Yet at the same time, they find the behavior to be positively reinforced. It's often self-soothing. So if you think of like thumb sucking, where as kids get older, it becomes less socially acceptable and actually can damage your teeth and different things like that. And so it's self-soothing. It feels good, but with older kids, certainly they want to stop if they're getting teased or the parents want them to stop. So that can kind of help you understand how this can, be something that you want to stop so badly, but also it's very hard to stop because it feels good generally. Okay, so there are lots of types of BFRBs. By far the most common that I see are the skin picking and hair pulling. I'll go through all of these. I don't even know how to pronounce all of the words of the technical words, but I will tell you that to treat these disorders, you have to be able to at least, say these conditions, not the technical name, but be able to say, like, for instance, hair eating without cringing or making any kind of face. And I know this sounds like odd that therapists would do this, but they do. Like, so if you don't feel like you can get past that, you probably shouldn't treat these disorders, because sometimes people will talk about things that may seem gross to you. And we have to understand that it may be gross to them too. They don't want to be doing this. But if we make a face or, anything show that we feel it's gross, then that just adds to that shame and isolation. They probably won't continue in therapy. So anyway, the two main ones, and the ones that are actually in the DSM now are the excoriation disorder, skin picking. It used to be referred to as dermatillomania, so a lot of people still call it that. And then trichotillomania, the hair pulling disorder. And then the other ones, the hair eating, so people will pull out their hair and then eat the hair. We'll talk more on that later, because that can cause a life-threatening condition. Then the nail biting, nail picking, so picking around, the nails or picking the nails off. Skin eating, same kind of thing as like with the hair. They might pick at the skin and then eat it, or they might just be like biting it off straight from their hand or somewhere else. Hair cutting as well is people that just compulsively feel like they have to keep cutting. It's not right. I have to keep cutting it. Lip biting. This is another, actually, lip biting and cheek biting are pretty common as well. Again, it's just more than the average kind of lip biting or cheek biting. It's like causing sores or major distress. And then tongue chewing, so kind of just chewing on the tongue. So to talk about how common are BFRBs, I think they're definitely underrepresented, or, we don't know most people have them because they are very well hidden. But the research shows about 1 in 20 people will struggle with a BFRB in their lifetime. It generally starts around childhood, around puberty is probably the most common, but sometimes it doesn't start until adulthood. And in childhood, it is equally prevalent in all genders. However, once reaching adulthood, or even like more into the later teens, we see about 90% of the BFRB sufferers are women. So there's a lot of theories for this. I think, it kind of makes sense that women tend to, these are all generalizations, please excuse that. And of course, I know there are more than two genders, but using the typical or, stereotypical male versus female, women tend to care more about their appearance. In our society, women's appearance is valued very highly. And so when women have, you know, uh, scabs on their face, it may bother them more than a man. Also, another thing is, for men, balding is okay. Balding, we think men who are bald can look good. Many person who used to co-lead the class with me was bald. We used to always say, yeah, look at Andy. He's, doesn't have hair, and that's okay. For women, not so much. It's much less looked upon as like a okay thing. So, but the key thing to remember too is that you may have many people in your life that are doing these behaviors. Many of your clients may do these behaviors, and you may have no idea. Most of the people I see do not tell anyone. I mean, literally, often their spouse doesn't know, their parents don't know. Sometimes you'll see, I will see also a lot where like the spouse or, close friends or parents know, but no one else. They can keep it very, very hidden. So these are some ways to hiding it. Obviously, makeup, wigs, or any kind of a hat or any kind of head covering, and then Band-Aids anywhere on the body could be common ways of hiding it. Okay, so people always ask, like, what causes BFRBs? And this is similar to a lot of disorders, there's many causes, and also, but for BFRBs especially, it really does vary among individuals. So there is a genetic component. We do see it tends to run in families, but not always, and often it's not diagnosed again. So sometimes people say, oh yeah, I do think, my dad bites his nails a lot, or my mom does pick at her skin, but, it was never diagnosed. So as I said before, it is often self-soothing. That is a pretty common thing, but again, not always. Some people don't find it soothing. Some people, it's more of a perfectionistic kind of thing. Like, I need my skin to be perfectly smooth. It doesn't feel right. So I need to pick to make it smooth or make it feel right. Same with the hair, maybe certain hair that is a different texture, or a gray hair or something. And like, I need to get rid of that. Or evening out like the eyebrows or eyelashes, needing to like make it just right, or so that can be related to OCD. We talk about it is in the DSM under OCD and related disorders. That's kind of maybe the best place to put it. Maybe it used to be something like impulsive behavior disorders or something. So it doesn't quite clearly fit with any because it's not always related to OCD at all. It is sometimes done by accident. So I'll hear people say sometimes they started like they were messing with their eyelashes and one came out and they're like, oh, that feels kind of good. And then they keep doing it. They also commonly do develop, to cope with uncomfortable emotions, or even however they develop, they're used in that way. So it can be like, when they're stressed after a long day, they go home, go in the mirror, and they're picking at their skin, kind of getting into like a trance-like state where they're just, the problems of the day kind of disappear. It's similar to like emotional eating in that way, just kind of like tuning out and doing this soothing behavior. It is sometimes related to ADHD or can co-occur with ADHD. ADHD can make it worse. And people always ask about the stimulant. Does that make it worse or better? It really depends on the individual. Sometimes it makes it better. Sometimes it makes it worse. Sometimes no difference. It often occurs when bored. That is a kind of common. So a lot of times driving, watching TV, either when the hands aren't very busy, or just kind of mind isn't busy, they may be kind of just doing the behavior. And then any stress in life will likely make it worse, similar to most other disorders. And then as far as the severity of BFRBs, that obviously really ranges. So I want to kind of give you like what it looks like and if it's mild, moderate, or severe. So in mild cases, it often will go untreated, maybe little or no distress or interference in the individual's life. I mean, to get the diagnosis, it would have to have some interference and distress, but kind of people sometimes go in and out of it. Times they're mild, or even it doesn't totally go away, but they get to the point of it not bothering them much at all. And then they'll at times slip into the moderate or severe. So in a mild case, maybe they're picking at mosquito bites or acne, maybe an average of about 20 minutes a day. So it's not a huge interference. It is interfering some, but not hugely. They may have some hair loss or scarring, but they're usually able to hide it easily. Like another common thing is changing the hairstyle, putting the hair up or down, or changing the part, that kind of thing, to hide bald spots. So then a moderate case, maybe they'll pick or pull like 2 or more hours a day. So that is now taking up a large part of their day. They may have noticeable hair loss and skin lesions. So you may either actually see bald spots or they may cover them. And then, they may have open wounds or using Band-Aids to cover. And then often they'll start avoiding important events and people. One of the most common things they avoid is swimming. Swimming is very hard to hide. A lot of the, if you're wearing a wig, it's hard to swim with the wig on, or you have to keep your hat on. It's hard to swim. And then exposing all the skin. Many people also use clothing to hide. So maybe wearing long pants and long sleeve shirts, even when it's hot outside, becomes a lot harder when you go swimming. Plus swimming takes away the makeup and so that is a very common one, but there's many people just avoid any social events. Maybe they don't come into work as often, different things like that, and avoiding people that they're afraid will judge them. And then in this moderate category, you'll probably see that they're frustrated with themselves and embarrassed when people may notice about a bald spot or ask about, why you're wearing all these Band-Aids. And then in the severe category here, some people are literally picking or pulling almost nonstop. I mean, definitely, it'd either be several hours a day in front of the mirror, or it could be not in front of the mirror and just, as they're working, they're picking or pulling. As they're, going through the day, they're just doing it almost all the time. You may also see in this more severe cases, more frequent skin infections, possibly requiring hospitalization. This is also where it does get very dangerous. I had one client who was hospitalized with a severe infection, and if she hadn't been hospitalized, would have died. So this is also a problem because, there's the embarrassment and shame, and people don't want to go to the dermatologist or even urgent care or their primary care doctor because they're embarrassed. And often they get from these medical professionals, "Why'd you do that to yourself?" Like, "Oh my God, what's wrong with you? You did that." And so they don't get treated, and that's where it then can get really severe. The other really thing to watch out for is that if they are swallowing hair, so some people, it's just part of the kind of self-soothing, will put the hair in the mouth. Some people will accidentally swallow it as it's in their mouth, or some people will swallow it as kind of part of the BFRB. If they're swallowing a lot of hair, and especially if it's longer hair, they can develop a trichobazar, which is basically a big hairball in the abdominal tract. So this also can be fatal. So and sometimes it gets very severe without noticing symptoms, or the symptoms can be easy to play off, or, easy to assume it's something else, like you're feeling constipated, or you're not as hungry, or you're throwing up, or, all those things don't necessarily, most doctors aren't going to think of this. So if you do have a client that is swallowing hair, I would recommend, this is what I was told, and I've told people to do this, it seems extreme, but to go to the ER and ask for an abdominal ultrasound to look for it, especially if they're having abdominal symptoms, but even if not, to be on the safe side, because it can develop very quickly and require surgery. So then often the other thing is this extreme shame, depression, isolation. I mean, that's really very, very common, as most people with BFRBs are really ashamed of it. They feel like they're a bad person. They feel like, why am I doing this to myself? I'm hurting myself. I'm isolating myself. And it just, leads to severe depression as well. And then people can become disabled, like unable to go to work because of the embarrassment of, not wanting people to see them with the effects of it, or some people have been told to leave work. Like I've heard of like hairdressers who have gone to work with like an open wound on their face, and their boss has said, you got to leave, you can't work here, it's not safe to be treating or working with people when you have that on your face. So, and then as I already mentioned, the skin infections and abdominal blockages can be fatal. So it is important to know these can get very severe. Okay, so now we'll have a little fun with some myth or truth. What I do want to do is go back to, let's see, the chat. So what I'd like you guys to do, let's start with the first one. BFRBs are a form of self-harm. If you could put in the chat if you think that's a myth or truth. And then I'll come over and look at the chat. Okay, I see truth, myth, truth. So a lot of both. And this is, so this is one of the most common misconceptions, but also I will tell you that there is some overlap, so it's not 100% clear. Generally, we say it is not the same as self-harm. The major difference is, and I'm not a self-harm expert, some self-harm experts will argue with me, and this is again a generalization. Generally, in self-harm, they are purposely causing pain or discomfort to relieve emotional suffering. Again, a big generalization. I know you can argue with that, but in BFRBs, generally it is not, they're not trying to cause pain, and they generally, most of the time, it does not cause pain. It generally feels good. It's more self-soothing. So it is, most BFRB experts will say it's not the same as self-harm. There is some overlap, and there are some clients with BFRBs who will say it's self-harm. And I'm not going to argue with my clients, and really I don't, need to argue with anyone about it. It's just I guess it's important, I think, to know the difference and not say it's just the same as self-harm, because it's really not. Some of the treatments actually do overlap. There's a lot. DBT works really well for BFRBs. But because BFRBs, there's so many different reasons why, and that's probably true for self-harm too. But as we'll get into this more, you really need to understand why they're doing it, because just applying what you would for self-harm or just applying, certain strategies may not work if that has nothing to do with why the person is doing the behavior. All right, so any questions on that? And you guys also can jump in and okay, what about BFRBs as a form of stimming? Okay, so yeah, that's a good question. So with that, with autism, for some people with autism, it is hard to treat the BFRB. Like if it is stimming, I would not treat it. If it is, if the person is not bothered by the behavior and it is not causing any infection or, abdominal blockage or like that, I would not treat it. It's not a problem unless it's a problem for the person. Now, this gets into issues with parents and children, and here we can get into arguments with, my kid is pulling out their hair, but they don't care. maybe they're, 8 years old, they go to school, they don't care that they have bald spots, but it obviously bothers the parents. I understand that. I'm a parent, it would bother me too. However, I don't believe that treating that child is going to help unless I would talk to the child and see, is it bothering you in any way? But if it's 100% not bothering the child and it's not causing any health risks, I would say, you could offer some strategies, you could give them a fidget, but I don't think treatment's going to be all that successful if the kid the person in general has to be motivated for treatment. So with autism, it really can vary, and I probably wouldn't call it a BFRB if it's more the symptom of autism. Are there other questions or anything? I want to make sure. Okay, but yeah, that's a good question. So let me go back because I can't read this without everyone who knows me knows I need glasses. Okay, I have glasses. Not gonna. So anyway, okay, back to so the next one is reminding the BFRB sufferer about how much better they looked before they started picking or pulling will help them stop. What do you all think on that? Is that a myth or truth? Okay, you're all saying myth. And so that's good. As therapists, you guys all know this. It seems common sense. To parents, it is not common sense. And again, I am a parent and I understand I make all the mistakes that I tell parents not to make, but it definitely does not help. That just makes them feel worse about themselves. It makes them, and then when they feel worse, generally they'll go and do the behavior more, or they'll just hide it better. Honestly, that's what kids and teens are going to do, is hide it from the parents if the parents are shaming them or just making them feel bad. So, okay, that one. The other, BFRBs are just like a bad habit. What do you all think about that? I'm saying myth again. Okay, and I think the way I phrase it when I say just like a bad habit, it's definitely a myth. The thing is, there is a habitual nature to it. It does become a habit in a way, but it's much more than just a habit. As you all are understanding, it is like a, compulsive behavior that is very difficult to stop. So, but some strategies that you see about like how to break habits and stuff definitely can help. There is a habitual nature to it, but it really minimizes their suffering if people say, oh, it's just a bad habit. The other thing that just reminds me of is people will often, even therapists will do this some, and it can help, but anyway, they'll like relating to them, trying to normalize it, like, oh yeah, I pick my skin too. That's minimizing too, because, and that's what friends will often do if like a teenager tells their friends, I have skin picking disorder. They'll be like, yeah, I pick my acne too. And sometimes that makes them feel better, but sometimes it is like, no, you're not getting it. Like, this is serious. I'm in the mirror, 45 minutes every night. You might be spending 5 minutes and, I'm making my skin a lot worse. And so just be aware of that, I guess I could say. I think it does help at first to normalize, to say, you know what, we all do these behaviors some of the time, but also I do understand what you're doing is a lot more harmful. Okay, I see a question. Would you say that N-acetylcysteine is beneficial? Also, can it be recommended for use in children? Okay, yeah, so that's a good question. The N-acetylcysteine, or they call it NAC for short, I don't get a lot into like medications in here that, well, honestly, because at least the latest research I've seen, there is no medication that has shown significant efficacy with BFRBs. That N-acetylcysteine is the most effective, and it's about 50% effective. Again, it's not a prescription, it's a supplement. I do believe children can take it. I always tell people, though, ask your doctor about this. You have to ask the pediatrician or primary care doctor, is this safe for me to take? The other thing I've noticed is it takes a long time to become effective, and people often don't wait that long. I'm meaning like 3 months, up to like 3 months or so till it can become effective, and you have to take a lot every day. It's definitely worth a try, though, because there's generally no side effects, and except taking these like big pills every day. And then, 50% is a pretty good recovery rate, or not recovery, but it helps in that. So I definitely, yeah, I appreciate you adding that, Lisa. But yeah, always just, as you know, as therapists, be careful not to, like, we're not prescribing it, we're just suggesting this could work for you. Okay, so back to, let me see, the next one. Okay, so this is another one that complimenting them on how nice their hair or skin looks when they've reduced the behavior will help them continue to improve. So once they're, let's say you see some hair growth, or, you know, like their eyelashes are coming in and they come into your session, you're like, oh, your eyelashes look great. You know, I see you're really working hard. Any thoughts on that one, if that would be helpful, I guess, to say truth if you think that would help them improve. Okay, I'm seeing kind of a mix here. So this is another where it's not so cut and dry. I would say generally it's a myth. Most people I've worked with BFRBs say they don't feel good when someone points out anything changing about their appearance. There's a couple reasons for this. One is it makes them feel like, oh gosh, I looked bad before. I must have looked horrible. Now you're seeing how much better. You're saying I look better. It's also just the idea of focusing on the appearance when that's just one part of what's going on. There's a lot underneath that you may not realize. So we really can't judge their progress on what we see. And so if someone says to me, I've really done better, my eyelashes have all grown in, I mean, I'll say, great job, you know, awesome. I'll definitely encourage that. But I generally will not point out that I see your skin looks better. Because that, yeah, you never know. They might be hiding it, or, you know, might be in a different part of their body they're picking now. And also, again, we just don't want to focus as much on the appearance. Any questions or comments with that? Okay, so go to the next one. People with BFRBs know when they're doing the behavior. What do you all think there? Do people know when they're doing the behavior? Yeah, so most are you saying myth or not always? Exactly. Yeah, yeah, myth most of the time. Yeah, so exactly. So this really varies. There's terms like called focused hair pulling or skin picking, or like automatic. So many people, and most people do some of both, but yeah, a lot of times people are automatically, just their hand goes up, they're driving, they don't realize that they're pulling, and then they'll, you know, see a bunch of hair on their lap, and then they realize it. Some people do both. Sometimes, like at times they're in the mirror, they're focused, they know they're picking their skin, and then other times throughout the day, their hand just goes up and they're picking, or to any part of their body. So yeah, it's definitely not something they're aware of all the time. If they really wanted to stop, they could. They must not be trying hard enough. Any thoughts on that? Okay, I'm having trouble clicking between these things here. I'm guessing, here we go. Oh yeah, you guys are saying false myth. Yeah, so that one's kind of obvious. Again, though, like obvious to us, but not obvious to others. You would just be shocked of how many people say this in their lives, their loved ones, doctors. I mean, there are some good dermatologists in the St. Louis area who I've connected with, and I'm sure throughout the world, but there are many, many more ones that make it way worse. And so again, yeah, they hear this from doctors, from friends, family, like you're just not trying hard enough. If you really wanted to stop, you could. Another huge thing that happens is once they're in treatment, then the spouse or parent will be like, you've been in treatment, you know, 4 months, like, are you not doing the homework, or what's going on? I don't see you're getting any better. Again, obviously we all know that's not helpful, and treatment isn't always going to work right away, or going to work in the way that others can notice. Okay, the last one here, when you notice the BFRB suffer doing the behavior, you should point it out to them. to help bring awareness to what they're doing. What do you all think on that? Yeah, myth, not true. I'm seeing both. Exactly. What I think it was Janice just said there is if gently and they agree to it, yes, that's 100% what I would say there is you so just pointing it out without having a plan ahead of time with the person is generally not a good idea. They again will feel like that shame and embarrassment or frustration. However, a support person can be very supportive in this way when a plan has come up, is come up with ahead of time. So what I often will tell parents and kids out in the session together, like, do you want your parent to point this out to you? If so, when? Probably never in public, probably, maybe only certain times of the day they want them to point it out. Maybe they're working on just at dinner time, not doing the behavior. So the parent could say, so then you usually come up with a code word or a signal that they could do. Another thing is just like a very gentle, like maybe just put your hand on their hand or put your hand on their shoulder, something that they know is a caring gesture of, I'm just letting you know you're doing this. But again, only if it's agreed upon. And also with that, what was I going to say? Oh, also it sometimes has to be, continually discussed. Sometimes they'll say, yeah, I want you to point it out. Like, okay, now, right now, I don't want you to point it out. Just whatever the BFRB sufferer wants is what's best. Okay, I see a question here. Does BFRB ever occur during unconscious states like sleep, specifically soothing themselves by running fingers through their hair, leading to some minimal hair falling out? Okay, so that is less common, but I have heard of it. Yeah, it's definitely less common to happen in their sleep, but again, yeah, I have heard of picking. I can remember one person that I saw in one of my groups a while ago who would, wake up and she had really destroyed her face in her sleep. So a lot of the strategies, though, can help a lot of people. Before falling asleep, also, though, is a very common time to do the behavior. So a lot of times people will wear gloves or Band-Aids on their fingers to help prevent them from, either just doing it while they're awake or while they're asleep. Just a Band-Aid around like the pointer and thumb or one or the other, whatever hand they usually use to pick, or multiple fingers, can help. It makes it harder to pick or pull and also brings awareness to it. Let's see. Would teeth grinding be considered BFRB in sleep? That's a good question. I am not sure. I'm trying to think if I would have to say, I'm gonna have to look into that. Thank you, Sasha. I'm gonna look into that. Are there any other BFRB experts in here want to chime in if you know the answer to that? I'm gonna, look into that. Okay, any other questions at this point? And then we'll move on because I see we have a lot more to cover here. Okay, so we're gonna go back to present mode. Okay, so how do you diagnose a BFRB? The most important is the clinical interview. You're all doing this anyway. But what you're probably not doing, or at least I never did until I learned about this, is directly asking every client, have you ever had a problem with excessively picking your skin or pulling your hair or any other kind of repetitive behavior? I can't tell you how many clients I have had, that I started seeing before I really knew as much as I do now about BFRBs, who, 5-10 years later will say to me, I saw your flyer out there about a BFRB, in the waiting room. I just read, I think that's what I'm doing. I actually am picking my skin, and I never noticed. They didn't know it was anything to bring up. So again, it's occurring with lots of people, and, we're treating other things. It could be depression, PTSD, OCD, anxiety, anything. And no one thinks to bring up the skin picking, or they're ashamed and embarrassed and are not going to bring it up. But if you directly bring it up in part of your, clinical interview, I think that's the best time to bring it up. They still may not admit to it, or maybe they'll minimize it, but at least you're acknowledging that it is a problem that other people have, and that may make it easier to bring up than just out of the blue them bringing it up. If you've been seeing people for a while, you could just add this in like, hey, I just learned about this thing. I'm just asking all my clients, even though I've seen you for years, just want to check in if this is something you do. And then, of course, in order to diagnose, you need to determine whether it's interfering with their functioning or causing significant distress. And I want to point out, you do not need to actually see a bald spot or skin lesion to diagnose. I would never ask to see that. What people have told me, some people will show you, and that's fine. They want to show you it. I would look if they're trying to show it to me, but I wouldn't ask, because one person is particular, I remember, and then everyone in the group related to this said that it feels like you're like getting undressed, like naked, just to even like lift your hair and show a bald spot, or to, remove any kind of covering to show that it feels like being naked. And so I would, recommend not asking to see unless they want to show you. And then so there are the DSM and ICD codes are only for the hair pulling or skin picking disorders. The other ones, I usually will just see, is it more similar to hair pulling or more similar to skin picking, and diagnose with one of those, even though if it is, like nail picking, put it as skin picking, that kind of thing. But right now, those are the only two in the DSM. And insurance does pay for these if I've had many people, that's their primary diagnosis, and I bill insurance, and it's no problem. They are regular codes, just like any other disorder. And then there's questionnaires. I say these are optional. It can give you more information. I don't think it's necessary. I use them sometimes, but not all the time. So there's the Massachusetts General Hair Pulling Scale, a skin picking symptom assessment scale. There's an NE-Y box, so like similar to the Y box we use for OCD. This is specifically for the NE is neurotic excoriation. And then hair pulling distress and impairment scale that can help, determine how much it's impairing them. But again, the necessary part is just asking those questions in the interview. Okay, is that a question or someone just coming in? Maybe someone coming in. If you guys do have a question, you can unmute and shout out if you want. Otherwise, I'll come back to the chat and get questions later. Okay, so the evidence-based treatments for BFRBs, the first one that and I think most of the research still points to, is cognitive behavioral therapy. And then habit reversal training is a type of CBT that is used also for tics and maybe other things as well. So habit reversal training is basically, it starts with awareness training, because with tics and with BFRBs, often they don't know that they're doing them. So we work on building that awareness. And then when they notice that they're doing it, coming up with a competing response. So a common one for hair pulling and skin picking, kind of the first one I usually teach people, but then people can make modifications, is clenching your fists. And then I was originally taught like holding your hands at your belt line, like where your belt would be, and just kind of again, clenching and just kind of holding there. So you can do it like under your desk or wherever people may not notice, and holding that for about 30 seconds to a minute, and then alternating that with like 30 seconds to a minute of deep breathing, and then going back and forth. So the competing response, so most BFRBs, now with the exception of like the lip biting, tongue chewing, cheek biting, for that we have to come up with another competing response, but most involve the hands. So if your hands are clenched, you cannot be doing the behavior at the same time. It also kind of wears out those muscles. People say it just kind of, sometimes it'll help the urge to pass because they're doing something with those muscles, rather than if we say just take deep breaths. That can be helpful for some, but for some people it's like, I need to do something. So that habit reversal training that's been evidence-based treatment for a very long time, and still very effective. One of the things I use all the time. And then ACT has also been, there's definitely some evidence with that, and I use parts of that as well. I'm not fully trained in ACT, so I won't speak much to that, but there definitely is some evidence, and there's even, I think, like a workbook on ACT for trichotillomania and different things like that. So, and then DBT, same kind of thing. Again, that's not my specialty area, but I use some of the DBT skills, and it can be helpful, and there is evidence behind that as well. And then a newer treatment is the comprehensive behavioral treatment for BFRBs. So this is a specific treatment for BFRBs. They call it COMB for short, or COMB, some people will say it. And so at the end, I'll show you a book that somewhat recently came out on this, but this is, I use a large part of this. I also include, like I said, some of those other ones, but this treatment really gets at why they're doing the behavior. Well, not only why, when, where, how, why they're doing the behavior, and then coming up with specific targeted strategies to address those when, why, where, and how. So the major thing that often will happen is people just get a list of strategies, or people say just use fidgets, and fidgets can help. Band-aids can help. There's a lot of things that help a lot of people, but it really is not going to be effective long-term unless you're targeting the specific reasons and, again, where they're doing it and why and how, all of that. So I highly recommend looking more into that treatment approach if you don't know about that. And again, at the end, I'll give you the resource of the book. And then mindfulness is, there has been more evidence coming out about it. Obviously, mindfulness is evidence-based for awareness, increasing focus, increasing emotional regulation. All three of those are key parts of, helping with the BFRB. So I have found that really stressing the mindfulness, or actually starting with the mindfulness and having like a daily meditation along with the comprehensive behavioral treatment, is giving people the best success. So really putting those together. Okay, so why is treatment not working? So a lot of people is like, I've used these treatment approaches, it's not working. What I found is the most common reason why it's not working, well, there's kind of the two. One, I already said, like, you're just randomly kind of using strategies and not directing them to the specific need. But the other key thing is people are focused on stopping. So if their focus is, I have to stop this behavior, and the therapist is all talking about stopping the behavior and doing reward charts about, can you go, a day without doing the behavior, then you're focusing on the wrong thing. So what happens is that people cannot completely stop this behavior. Even people in recovery are still doing the behavior occasionally, and sometimes more than others. So if you're focused just on stopping, then you're just in this cycle, this endless cycle of blame. Every time you screw up and you do the screw up is even I would call it a slip, not a screw up, but what they will tell themselves is, oh no, I screwed up again. What's the point of trying? Then they're feeling angry, sad, hopeless, and it just leads to more of the behavior, and they just feel, they're blaming themselves. They just feel worse and worse and never really getting better. So what I have found successful is a combination, again, of those evidence-based treatments. So starting with really awareness of, like I said before, when, where, how, why they do the behaviors, and pairing it with specific strategies. Another key component is self-compassion. Very, very key, I believe. And I have found that without self-compassion, long-term recovery is not likely, because even if people, they might go a month with very little picking, or maybe even none at all, and then they slip, and then they beat themselves up. We all do that kind of thing when we slip on our goals. But if they can't recognize it and stop, and then be kind to themselves and use that self-compassion, it's very hard to get back on track. The other very important key is support and accountability. The support can look different ways. It can be a parent, it can be a therapist, it can be a spouse. And I'll talk next about kind of a group atmosphere, why I think that is very good support, but it doesn't have to be a group. It can be one-on-one support. But accountability, regularly checking in, having someone working with you to kind of check in. Or it can be accountability on your own if you're really good at like setting reminders to check in with yourself. And then so people who have recovered are able to consistently manage the behavior so that they can live a full, normal, healthy life without the suffering caused by the BFRB. So again, they're not maybe completely stopping the behavior, but they can do whatever they want to do. They're not avoiding the things they want to do in life, and it's not causing any, significant distress. Okay, I'm looking at the time. I got to kind of go through this quickly. So how is long-term recovery reached? So this is kind of like a summary of what I've said, but these are like the things that I think are most important. So motivation and commitment to treatment. You have to be motivated and committed. Daily mindfulness meditation, as I said, increasing awareness, focus, emotional regulation. Tracking to determine when, where, how, and why they're doing the behavior. And then identifying, so this is from that Combe model, identifying sensory, cognitive, affective, motoric, and environmental triggers, and then accompanying these strategies directly to it. By the motoric, I wasn't really understanding that word at first. What they mean is like the automatic. So looking at those like motor movements, like where is your hand resting? If your hand is resting on your desk and then, your elbow's resting on your desk and then your hand's resting on your face, is that more likely? Or just noticing those automatic kind of motor movements and strategies for that. And then rewarding the strategies, the use of strategies. It doesn't matter, at least at first, we really don't want to focus on whether they're stopping or reducing the behavior, just reward using the strategies. And I don't reward, but I have adults reward themselves. Rewards are hard generally for people with BFRBs to give themselves because they don't think they've done well enough because they haven't stopped the behavior, but I very strongly encourage rewards. Then another thing that I've taken, this is from mindfulness-based cognitive therapy that I also teach, comes from the sitting with difficulties or working with difficulties meditation, sitting with difficult feelings. I do a meditation on sitting with the urge and then teach how to gradually sit for longer periods of time. Maybe it starts with 1 minute and then gradually can go to 10 minutes and gradually longer, where you can feel the urge and watch it pass, like an emotion, and just, or even if it doesn't pass, that you don't have to do the behavior. And then, as I said, self-compassion, very important. And then I also have a component on gradually facing their fears or uncomfortable situations, like going swimming. So teaching that, just gradual exposure. And then establishing a support network is very important. And then a relapse prevention plan, including like the plan for the support person or people and how they're going to check in and when. Okay, we're almost done with these slides. So the other key thing I want to point out is like how group is so important. So I have been doing this individually and in group settings, and I find people in the group much more successful. So it normalizes the behaviors, which decreases shame. There's that connection through the shared experience of the behavior and the shared experience of treatment. They learn from others who are working through the same things. People will say, oh, this worked for me. And then the increased accountability. Group accountability is much stronger. People will say, I was thinking of the group members and I was like, oh, I gotta use my strategy so I can come back and report to the group. The shared understanding and validation hugely reduces shame and isolation. I mean, these are the key things that group can really do. And behavioral modeling, so seeing someone doing well, like, okay, I want to be like this person and keep doing it. And then also people say they feel good about helping others. They show up for group, not just for themselves, but for these people they've learned to care about as well. Okay, these are some quotes. I know we are short on time, so maybe what I'm going to do is email out these slides and you guys can read through these. But these are a few quotes that I got from people who have taken the online course. So they're actually not clients. We're not supposed to get testimonials from clients. I'm sorry, they are not patients. They are coaching clients. And they are in my monthly alumni group and gave me these quotes that I could use. So you can look through those later. Okay, so the resources, the book I talked to you about is that Combe model. And I have a Facebook group. Some of you may be in or not. Again, I'll email the slides, which will have the links to all these. There is if you're a therapist and want to learn more and really become a BFRB expert, we need more in the area, well, all over the world. And it's a 5 CEU self-paced course. So it's over 5 hours, but a little over 5 hours. We get 5 CEUs. And I am going to offer now 40% off for the first 8 who sign up. And then we do have courses here at the center, our groups here at the center, and then courses online. We do have one enrolling now. So if you have clients that you think would like to do the group, you can refer them to our website. Okay, any questions? I apologize for going over here. Let me see if there's, okay. Okay, my 6-year-old has a tic disorder that involves large body movements. However, he also has selective mutism, will not communicate with anyone he perceives as an adult. Which of these treatments would be effective? Yeah, that is tricky. Large body movement. So is he harming his body? I think that one is a tricky one that we might have to come back to. If you can also email me, Sasha, you're asking good questions and I can take some time and think on that. Let me see. Have you worked with someone very young with BFRB? My 3.5-year-old picks. Okay, so yeah, this is hard with the younger ones. I have worked with parents on some strategies that can work, but obviously like with the younger nonverbal or less verbal kids, I mean, even infants can do these behaviors. If it's not causing any damage, I would generally ignore it. Maybe just like you would for babies that accidentally scratch themselves, they can wear those little mitts on their hands or something. But I would say, yeah, again, it depends on if it's harming them. But I have worked with parents of young kids, yes, and yeah, hard to come from it. Yeah. Does that answer your questions? Sorry, there. Let's see. Until they bleed. Yeah, to come rather than a strict mom. I mean, so yeah, the thing is, or a strictly mom. You're not saying strict. Yeah, it is. It is hard. I mean, it may be better in that case, even for you to work with a therapist yourself on this, because that's what I found with parenting. The knowledge isn't enough. We need like that accountability and that someone else to see it from an outside perspective. Other questions? Let's see. All right. Well, thank you all for hanging in there. Oh, there are more questions. Sorry. Oh, Stephanie's saying she has to leave. Okay. Oh, it's causing bleeding. Okay. So Kristen, you're saying you're the one with the 3.5-year-old. Okay, so it's causing. Yeah, I mean, I would say, I mean, I could do like a consultation with you if you wanted to, or you can, find a therapist to work with you regularly. I think there are some ways you can kind of use this treatment. I mean, or parts of this treatment, just especially like the, covering the hands or finding maybe other things. It's hard at that age to know what their need is, but generally that's what we want to know is like, what's the underlying need? So yeah, I think those are good questions, but it is complicated. And I think, it would just be good for like a consultation at least. And yeah, feel free to email me, everyone. Well, you guys all got emails from me with the links. You have my email. If you have questions, email me. I will send out a recording as well as the slides so you guys can look back on those as well. All right. Well, thank you all so much for attending and participating. And yeah, I hope to hear from you with questions or anything. I hope you guys will use this in your work and be helping more people. Thank you guys. Take care.